Next up, our session will be on human factors, and we would like to welcome Dr. Alvin Wu, who's a family physician and medical officer at Singapore Aeromedical Center, and David Lim, co-founder of Kestrel Aero. Both are joining us from Singapore today. If Alvin and David are ready, feel free to begin.
Hi everyone, my name is David, and it's with great pleasure that we are invited to give this human factors presentation at the AsBAA Safety Summit. And yeah, so we'll be doing a co-presentation. The first part will be on specifically fatigue management, and Alvin will take over for the second part, where we'll touch on high altitude physiology, followed by a question and answer at the end. So yeah, without further ado, let's begin. And first up, I want to check if everybody can see the screen sharing okay?
Yep, I can see it.
Alrighty, so yeah, human factors, fatigue, and increasingly in aviation, fatigue is becoming one of the key watch areas due to the long hours of flight, due to sometimes flying in the middle of the night. So it is a very interesting topic, as I shall elaborate in the subsequent slides. Okay, first, the definition of fatigue, because it is pretty vague, right? So according to the Fatigue Management Guide published by IATA, ICAO, and IFALPA, fatigue is a physiological state of reduced mental or physical performance capability, which results from sleep loss, from extended wakefulness, circadian rhythm, workload, and that can impair a person's alertness and ability to perform safety-related operational duties. So the point that I'm trying to make here is really, there is no distinction between fatigue and being tired, because the physiological effects of the symptoms are going to be the same. So if you're unable to function, it falls under the IATA and ICAO definition of what fatigue is. So what is it? It is really a physiological necessity. It affects all operators, operators in the military, the airlines, business aviation, in aircraft maintenance, air traffic controllers. And this physiological need to sleep is similar to that of food and water. So it will not be overcome by superior willpower. You can't will yourself not to have to sleep. And in order for you to function, it is absolutely necessary. So I just want to bring that out as a physiological need. Okay, so in research that talks about fatigue prediction, there are two key factors that affect the extent of the fatigue that you will experience. The first is a duration of wakefulness. That is usually directly related to duty duration. If you have a long day, say a 14 hours duty day, you are likely to be more fatigued towards the end of the day as compared to somebody who's just started duty within a few hours. The second factor is circadian rhythm. Many of us are familiar with that aspect of biology. So essentially, most normal human beings, they experience a very low circadian rhythm from the time from 2 a.m. to 6 a.m. And sometimes flights take place during that time, right? And then naturally, as you wake from your 8 to the rest of the evening, your circadian rhythm prompts you to be more alert. So what about red-eye flights? So in red-eye flights, essentially what you're doing is you're fighting that circadian rhythm. So therefore, you have to adjust it in order to function effectively in the flight deck, or if you are doing other maintenance tasks within aviation. Okay, and next I want to talk about why fatigue is a tricky subject, right? It is. In my time with the airlines, I've been on a couple of fatigue management committees. It is very relatable to safety. So, and there are three challenges that makes fatigue tricky. The first is fatigue is really hard to measure objectively. If you take the analogy of alcohol testing, you can bring the pilot through a breath analyzer and you get a concrete measurement, right? But currently for fatigue, there really is no test that can effectively test how fatigued you are. And the second is a fear of repercussions that may inhibit fatigue reporting, because imagine going to your flight manager, right, and telling him that you're tired, you can't fly, and sometimes it's got to do with reasons that's beyond our control. But say if you go up to him a couple of times a month and decline the flight, what will happen is there are going to be likely repercussions, right? So therefore, it makes the fear of repercussions severely inhibit the actual reporting of fatigue. Okay, and the third factor that makes fatigue hard to handle is that some countermeasures for fatigue, like stepping down from a flight, it does conflict with productivity goals of the flight department. So if you have to replace a pilot, overall your head count has got to be increased. And because of all these factors, it makes fatigue a tricky subject to handle from a safety perspective. Okay, and we all know that fatigue, every operator knows that fatigue affects us, it hits us at some point. So this very short case study talks about a US incident where a Cessna CJ4 pilot failed to engage the autopilot after takeoff. There was a crash, there were no survivals, and this happened in 2016. He's been awake for nearly 17 hours and likely fatigued. So the reason for bringing up this case study is fatigue is one of the contributory factors, but at the same time, there are many other contributory factors to this, like for example, understanding the automation that the state of the automation that the aircraft is in, possibly spatial disorientation in darkness. So it's very difficult to attribute this case study or this accident solely to fatigue, which makes it challenging to sometimes diagnose factors and also to understand what is the level of contribution and how should we address the problem. In this presentation, I'm going to touch on two levels of fatigue risk management. One is at a systems level, which I'm going to do so now, and the other is at the individual level. So at the system level, the industry is gravitating towards FRMS, or the fatigue risk management system. So what it is it is a data-driven means of monitoring fatigue. It relies on scientific principles, and it incorporates a performance-based approach to regulations. So it's very similar to what the safety management system is. It has four key components. The first component is that of policy and documentation. The second component of risk identification, hazard identification and risk management. The third component on assurance, basically audits and the monitoring of safety and fatigue related performance indicators. And the fourth is that of promotion or education. So these four pillars form the foundation of a modern fatigue risk management system. Earlier we talked about fatigue and the difficulty in measuring it objectively via a test, right? So the current industry means of measuring fatigue is via subjective assessment, self-reported by the operator. There are a couple of well-known scales that are used within fatigue reporting. The one that is perhaps most commonly used is the Samparelli scale, And if you look at the table over here, the Sam Pirelli scale from 1 to 7 has various levels of alertness and how the operator is feeling at this time. And this is the primary means that flight departments, regulators get a sense of how fatigued the operators are feeling on the system level. In the airline side of the house, there is a very active use of biomathematical models, or BMMs. One of the more prominent ones that is used by Singapore operators and CAAS is SAFE. Essentially what it allows you to do is to input certain duty duration and your past rosters, and it will come up with a score that's correlated with the Sam Pirelli scale, allowing you to predict how your operators will be feeling at a particular point within their next flight. And we've also talked about, a prescriptive and a performance-based approach to fatigue risk management. The prescriptive approach is what we've been doing for years, right? With maximum flight and duty times stipulated, and you're not to exceed it. And on a regular basis, you can, however, seek a waiver for it in extenuating circumstances. What the industry is gravitating to is a performance-based approach, where now it is based on data, and you can actually very closely and very finely manage the fatigue risk within flight operations, but data is very important. So what it does for the air operator is essentially, it provides a venue of flexibility to suggest that you do not want to follow stipulated duty durations with very good reason, with scientific backing. So therefore, it allows you that flexibility to adjust your flight operations. So that's at a system level. On the individual operator level, there are many aspects where you can, many countermeasures that you can take in order for you to avoid fatigue risk. The first is a restorative break, getting up from your seat, go getting a coffee, and that's considered one of the ways of having a restorative break. Caffeine can be a tactical countermeasure, and also self-discipline, ensuring that you report for work rested and fresh, keeping personal matters away from the flight deck, incorporating a regular exercise and healthy diet into your daily life so that you maintain fit and healthy for flight duties. And one of the more controversial type of countermeasure is actually CRFD, or controlled rest in flight deck. It's also known in other terms, controlled rest in position, when it's allowed by regulations. Diving a little bit more into controlled rest on flight deck, essentially what it is it's been practiced for years, right? So a pilot announces that he's going to take a break. He rests his eyes and ideally goes into a very short cycle sleep, while the other pilot remains alert. So the controversy that's associated with a CRFD is that it is not allowed by all regulators. In Singapore, it is. And we've found that it is, when you allow it and when you regulate it, it produces very good results. It allows the crew to be awake at the critical times of the flight. It improves performance, it improves safety. And fatigue reporting is one of the key ways that we can go about enhancing FRMS on the system level. So this is an MBA recommendation that if you need to take relief due to fatigue, please report it, and so that the system can capture it, and it allows an ongoing refinement of fatigue mitigation strategies. Next, we shall cover what are the specific challenges for business aviation, right, as compared to, say, the airline environment. Firstly, in business aviation, there's a smaller population of pilots. That results in less data, and less data actually prevents us from processing that data effectively. Smaller flight departments also mean that there are less opportunities to relieve fatigue pilots as compared to, say, a 300 or 400 pilot population within an airlines. Many of our business jets, they may not have proper crew rest facilities as compared to bigger jets like a A380. That effectively limits the quality of rest that you can have when you are taking a break. And also more ad hoc patterns leads to less structured data as compared to scheduled airlines. The second last point is the lack of reporting venues and opportunities, sometimes within the regulator or a flight department, prevents the actual data from being collected. It prevents managers from actually understanding the actual extent of fatigue risk within his flight department. And the last point is actually a proposal because I think a AsBAA-led reporting structure can do a lot of good for this community. Because in Asia, a lot of our regulators could be based in the US, it could be based in Australia. And while they individually collect data, it is very difficult to compile. Whereas AsBAA is in a key position where you can submit the data and this data will be processed solely for this area. So this is my proposal, something to think about. And I think this is an area where there could be a lot of contributions for AsBAA. And this is my last slide. Fatigue is a real risk, so do not allow it to compromise safety. So yeah, I'll be taking questions after Alvin's presentation. Over to you.
Thanks, David. So let me just go on to share my slide round. And okay, so I assume everyone is able to see the slides.
Yep, you're good to go.
Thank you. My topic on this part of the human factors has mostly got to do with how our human body reacts when we are exposed to high altitudes, and particularly what are the challenges and opportunities that the business aviation should be able to expect and face. So just a little background, we do need to understand that we are all surrounded by an envelope of air on Earth, and that is otherwise known as the atmosphere. It changes dramatically as we head up in altitude. And at the layer of the troposphere, just at the bottom, where most flights take place, the temperature, as you can see to the right side, it drops by about 2 degrees Celsius every 1,000 feet increase in altitude. And it can go as low as 50 degrees Celsius, negative 50 degrees Celsius. And as we get further away from Earth, the gravitational pull on the gaseous atmosphere decreases. So this allows air molecules to be more spread out as they're further away from Earth, resulting in a lower atmospheric pressure. So there is an exponential drop in atmospheric pressure as altitude rises, which is measured in millimeters of mercury. At about 33,700 feet, just 4,000 feet above Mount Everest, the atmospheric pressure is only a quarter of sea level atmospheric pressure. So essentially, air gets a lot colder, it gets a lot thinner, it gets harder to breathe, pressure goes down, oxygen molecules are more spread out, and that presents a physiological challenge for the body, for the human body to have to react to all these circumstances. So in the atmospheric air, there is always 21% of oxygen, regardless of where we are in altitude. What we have to understand is that the atmospheric pressure decreases as your altitude increases. And so because it drops with increasing altitude, the portion of atmospheric gas that comprises oxygen also reduces proportionately. This is otherwise known as Daltons Law, which is one of the few gas laws that we know of. So if you can see this slide, it shows that the absolute amount of oxygen at 18,000 feet is reduced by half because the total atmospheric pressure is reduced by 50% as well. And so the lack of atmosphere and henceforth the lack of oxygen can cause major physiological problems. So the areas of the human body most affected by high altitude are the respiratory and circulatory systems. Now, I know that we have this whole COVID situation aside. This is because oxygen is the most important gas that is utilized by all the cells in the human body, and it needs to travel through a series of tubes. So if you look at the bottom left picture, as it goes through the nose, the mouth, the throat, the windpipe, and the lungs. And within the lungs itself, if you can see the bronchiole and the alveoli, these are all numerous small sacs. This is where oxygen diffuses into the bloodstream, and they are picked up by red blood cells. And the structure of red blood cells is actually made up by 4 groups of protein known as hemoglobin. And the hemoglobin is able to bind to this oxygen in order to transport it around the rest of the human body to the rest of the tissues. And so the way that oxygen diffuses across from the alveoli air sacs into the bloodstream is actually driven by pressure. And so at sea level, where we all are right now, the atmospheric pressure is high enough that there are more than enough oxygen molecules that can pass from the external environment into the bloodstream. This is not so when it is at altitude. Because the number of oxygen molecules drop as the altitude increases, we cross from the physiological efficient zone between sea level and 10,000 feet to the physiological deficient zone up to 50,000 feet. And at that level, 10,000 feet to 50,000 feet is where most flying is actually conducted. And you can see that if there is no additional oxygen that's provided to the human body at that altitude, the blood oxygen saturation levels can drop to as dramatically as low as 1%. And we know that at about 60% blood oxygen saturation levels, the body cannot function. And it is just basically between anywhere below 90%, it is generally harmful to the human body. So therefore, for unpressurized flights to or above 10,000 feet, supplemental oxygen will need to be used. So as blood oxygen levels drop, insufficient oxygen is delivered to body tissues. This is known as hypoxia. And the one major organ that is most sensitive to drop in blood oxygen levels is our human brain. While the body has some mechanisms to ensure continued blood flow across brain cells, these mechanisms are just temporary. They cannot sustain continued higher brain functions unless the state of hypoxia is corrected. And what is more serious is that the symptoms of hypoxia are insidious. Pilots or aircrew may not know that they are in this state of hypoxia unless they are able to recognize certain symptoms which are specific to hypoxia. So if you were to look at the whole cardiorespiratory system in relation to hypoxia, if we need to deliver sufficient oxygen to the organs and tissues, we need to have good overall transport means. And that's how the respiratory and the circulatory systems of the human body work. They are intertwined with each other. If you look at oxygen molecules, they are the goods that need to be transported by the trucks, which in this case are the red blood cells and the hemoglobin. And the blood vessels provide this sort of highways and roads whereby the red blood cells can travel with the oxygen molecules to the rest of the body. Now, if we were to look at someone who may be having some form of cardiac disease, such as a previous acute myocardial infarction, a previous heart attack, it goes to show that the coronary arteries, the arteries that supply the muscles of the heart, they can be blocked by fats or can be blocked by other means. And when that happens, red blood cells, hemoglobin, the trucks are all jammed up. They are unable to bring their goods, which is in this case the oxygen molecules, to the muscles of the heart. And in that case, that causes the heart to be unable to pump efficiently. And so when we look at all these transport systems in the cardiorespiratory system, we are able to understand where the various causes of hypoxia can occur. Of course, the one that we always talk about firstly will be at high altitude, simply because the number of oxygen molecules, the goods itself, is just insufficient. And that is otherwise known as hypobaric hypoxia due to low atmospheric pressure. Of course, in this current setting with the pandemic going on, any sort of lung infection can also result in reduced gaseous exchange. And so oxygen cannot diffuse from the external environment into the bloodstream. If there are insufficient red blood cells, or the arteries and vessels are not moving, and also at the same time, if the cells are poisoned because of whatever toxins it is, they cannot use the oxygen. And so we need to understand that different causes can add up. And in the medical opinion we would advise that aircrew should go for regular medical screening, checkup on top of whatever their licensing requirements are for them to be at the top of their medical health. And the respiratory system of the human body may also seek to increase oxygen intake by increasing the rate of breathing. This is known as hyperventilation. So when that happens, you can take in more oxygen, but at the same time, you have to give something out. And in this case, would be known as carbon dioxide loss. This changes the chemical composition of body fluids. And in that case, it gives various sort of symptoms, which will be explained in the next slide. And hyperventilation is not just triggered by hypoxia. It can be things which are due to emotional aspects like fear, anxiety, and excitement. And the symptoms of hyperventilation are very similar to hypoxia. They may be not as insidious because they are just more florid in symptoms, but it is pretty much the same. If you look at the first 5 symptoms, dizziness, tingling sensation, numbness, fainting, and vision impairment, these are something which are also similar to hypoxia symptoms as well. But of course, the chemical composition of the blood changes, so that results in other additional symptoms such as muscle tremors and muscle cramps. So how do we manage both hypoxia and hyperventilation? For hyperventilation, we need to advise patients to slow down their rate of breathing and try to increase the carbon dioxide content of the air breathed in. So sometimes you hear people, oh, breathe into a bag so that you can recycle its expired air. But because when we're at altitude, we can't tell the difference between hyperventilation and hypoxia. In both cases, we usually would require them to have supplemental oxygen as well. In addition to a reduction in atmospheric pressure and gaseous molecules with altitudes, gas also expands. And when atmospheric pressure falls, the volume of air will increase. This is governed by another of the gas law, which is known as Boyles Law. And how does this affect the human body? Basically, the human body has several cavities that contain varying amounts of gas. And it's in basically 5 areas: the middle ear, our sinuses, our gut and intestines, teeth, and of course, the main air organ in our lung, which is our lungs. And basically, most of these cavities have an opening that will allow the gas to enter and escape. So if you think about if the opening itself is blocked, in this case, which is if the middle ear, the eustachian tube is blocked, or the sinuses, the draining tubes are blocked, or our gut is blocked as well, due to whatever food that we've already consumed, the gas is then trapped. And once it's trapped, the surrounding tissues can be subjected to gas expansion and compression in accordance with Boyles Law, and that causes what we call pressure effects, also known as barotrauma. So this typically results in pain in the various cavities at either the ascending or the descending phases of flight. And so, for example, during ascent, gas will expand according to Boyles Law. Air that is present and trapped in the face, in the facial sinuses, in the teeth, as well as the gut, can cause facial pain, toothache, and abdominal pain, respectively. And then during descent, because the volume decreases, the middle ear cannot equalize the pressure from the outside. The atmospheric pressure can be pressing on the tympanic membrane, which can cause ear pain and blocked ear. Similarly, it can also happen to facial pain. So other physiological effects at high altitudes include altitude sickness and decompression sickness. These typically occur only after exposure to high altitude for prolonged periods of time. Due to the drop in atmospheric pressure for decompression sickness, nitrogen bubbles can form due to reduced solubility at lower pressures. This is more pronounced in unpressurized aircraft flying above 18,000 feet and those who went for underwater diving prior to flight, among other factors. At the same time, altitude sickness can also present because of prolonged periods of hypoxia. So moving forward, business aviation entities have several opportunities in tackling high altitude physiological challenges. This includes recommending regular aviation physiology training to ensure aircrew are up to date with physiological effects and problems, allowing for aeromedical input in designing and operating newer aircraft to maximize human performance, and ensuring that aircrew undergo regular medical screening with prompt occupational medicine input in the event of any health problems to return them to the flying status promptly. And for the Singapore Aeromedical Center, we are able to offer all of these services as the largest provider of aviation medicine services in Singapore, comprising both clinical as well as educational and training packages in aviation physiology and related topics. So I've come to the end of my presentation. David and I would be more than happy to take any questions from the audience. Thank you.
Thanks, Alvin. That was informative, and I've learned a lot from it myself.
Thank you.
We'll give it a couple of minutes, yeah. And if there are no further questions, yeah, we'll end the session in a couple of minutes.
Yeah, don't be shy, guys. They could be typing or they could be thinking, so we'll give them a few minutes. I have a question for you, Dr. Wu. As an airman, I'm also wondering what are some of the first telltale signs of becoming hypoxic? As I'm becoming hypoxic, are there any sort of surefire signs that I can detect?
Yeah, so that's a very good question. So the important thing is symptoms, hypoxic symptoms are highly specific to various individuals. That is to say that despite the huge variability in the symptoms that patients may complain of, if you have been subjected to an incident of hypoxia, the typical symptoms that you feel would be similar across various hypoxic events. So let's say you've been exposed to hypoxia in a hyperbaric chamber in the training before, you may experience certain symptoms as I talked about earlier, such as giddiness. You realize that your visuals there's tunneling of vision. as well as you just find that your cognitive abilities are just not as well, not as good anymore. If you have gone through training before, you are able to identify that very quickly. However, sometimes this kind of symptoms may be confused with other problems as well, such as hyperventilation or even decompression sickness. So, of course, the surefire way would be if you just lose consciousness and you have no idea what is causing it, and it's likely to be hypoxia. But before we even get to that stage, what we want to know is what are the early signs that you can sort of know that you're having hypoxia. Right. And this is what we train aircrew for, that sometimes we tell them, okay, you might be experiencing some form of a headache, non-vertiginous giddiness, some hot flashes around the skin, as well as any tingling sensation in your fingers. So sometimes those are the more common symptoms that aircrew might experience before they really feel the full effects of hypoxia.
Thank you, Dr. Wu. We just received another question here. Let's see.
Yeah, so I'll just read that out on flight time limitations. Long distance flights are carrying 3 crew, one of which is resting on the plane all throughout the first flight so that a quick turnaround can be carried out. Thoughts on fatigue. So this is very interesting because there's a huge amount of variability among the regulators on whether you can carry this out or not. So if it is done, of course, it falls within current regulatory limits for your regulator. What I'd like to say is, in flights like this, where you run into instances where it becomes more challenging, consider fatigue reporting format to your flight department. Use a simple scale, use a Sam Pirelli scale 1 to 7. How do the crew feel at different stages on the flight, and particularly on the second leg, on the quick turn, the second leg just before the top of descent, particularly during the graveyard shift, window of circadian low? How do the people feel? So this allows data to be collected. And once there's substantial data, then you will be able to make a good assessment and make a collaborative discussion with your regulator on whether it should be safely allowed or not. So I hope this answers the questions from Xavier. And we have a question from Marcus also.
Yes,
that's right. I'll just read it out. It seems that data is so important. So the risk assessment input before each flight is important for human factors fatigue management. Needs mentioning, and kudos to management companies who have this in place. And aircrew need to submit these assessments every flight to populate the data and the risk data and the fatigue. I totally agree. So biomathematical models, the scientific models that we have, only gets better when people are conscientious and they put in the data for these models to improve. And in time to come, we will be able to predict it with a higher scientific accuracy. Thank you. Jeff, we have time for one last question, right?
Yes, sir. We have about 4 minutes left.
Okay, Jeff, I think we're good.
Okay, sounds good. Thank you very much to David Lim and Dr. Alvin Wu for your very informative session.
It was a pleasure. Thanks for having us.
Thank you very much.
Okay, our next session will begin in just a minute.